Hello, and thank you for attending. I'll be presenting this morning on neck dissection as it relates to thyroid cancer. I'm Brendan Stack from Southern Illinois University, and these are my disclosures, some of which are not particularly relevant to this discussion, although we do have a recent publication, a textbook on neck dissection in general, and there's a focus on endocrine-related neck dissections. So just to set the background, we've heard a lot about thyroid cancer over the last decade, and there's always been the question, why does it appear to be more prevalent over the last decade? As far as abnormalities in the thyroid are concerned, this is a frequent complaint that patients present with. As is shown on the slide, 40% are self-identified, 30% are physician-identified, and 30% are discovered on imaging. These are incidental findings, and this is certainly a reason why we're getting more of these cases referred to us, and that has been a concern as far as if we're finding a lot of things incidentally, and then if people are screening to look for these abnormalities, that results in a situation where we're getting a lot of findings that aren't ultimately of clinical significance. And so this phenomena can be looked at from two different perspectives. One is how many times are incidentally found lesions reported on scans versus how many times on these same scans or a subset thereof when the reader is particularly directed to look for a thyroid abnormality, how often are those abnormalities found? And when your attention is directed to a particular organ to scrutinize more carefully, you're going to find more abnormalities. In fact, this literature shows that there can be even a 10x increase in detection of abnormalities in the thyroid. So what has gone on with thyroid cancer over the last decade? And here is some historical data, some of which were projections at the time that they were published, and then I'll show you what's going on in a moment. In 2014, thyroid cancer prevalence was reported as about 600,000 cases, with an incidence of 63,000 cases per year. And this is from the American Cancer Society data set, which is updated every year. And we see more of this in women than men, and the breakdown is projected there for you. Now, if you look at more recent data from 2009, you'll see that the numbers are quite different than what was projected even 5 years before. And why was there a downturn for that? Well, before we talk specifically about that, it's important to place thyroid cancer in context with other malignancies. And on the left side, you see a waterfall plot, and the right side, you see life expectancy based on SEER data, and the red curve reflects thyroid cancer in all sexes and all races compared to all other malignancies. And so you can see that there's certainly a different behavior in thyroid cancer versus all other solid malignancies, such that some people have even wondered if this has the behavior of what most of us associate with as being a cancer. And certainly this is not to undermine the importance of thyroid malignancy, and there's certainly very aggressive cases of thyroid malignancy that can be as aggressive as any other solid tumors. However, its behavior is certainly different. So the objectives of this talk are to review recent developments in guidelines and staging as it relates to thyroid cancer, because there have been changes in these domains. To present the concept of neck dissection as it specifically applies to thyroid cancer, and to outline salient anatomy and behavior of thyroid cancer, which makes neck dissection for this disease a little unique than it would be for squamous cell carcinomas, and talk a little bit about the differences between managing the neck in primary setting versus in a recurrent setting. And specifically, we will outline techniques for central neck dissection, as this tends to be less demonstrated in residency training, and depending on your practice, a technique that's less frequently deployed. So this is a picture from a 16-year-old patient that was referred to me a few weeks after a total thyroidectomy, and you can see the thyroid is missing because she had already had that missing. And she was appreciated to have what was described by her and her referring physician as recurrent cancer, but this was not recurrent cancer. The course was too short from the time of her initial surgery. This was disease that was present at her initial surgery but was unrecognized. And this highlights the massive amount of cervical metastatic thyroid cancer that we removed from this patient. And this serves as a cautionary tale evaluation of the patient and the cervical lymphatics upon presentation, and then continued surveillance of this area after thyroid cancer surgery has been performed, if or even if whether neck dissections have been done previously or not. So some concepts that we'd like to emphasize include that the approach for surveillance and surgery applies to both cervical thyroid disease on presentation of the initial thyroid cancer, or after time has elapsed and may represent a recurrence or a delayed appreciation for microscopic disease that was present on presentation but not clinically appreciated. The purpose is also to understand the difference between a therapeutic neck dissection, which is excision of nodal levels which are positive for metastasis, and these have been previously biopsy proven, or I want to talk a little bit about the role for prophylactic neck dissection. Now, generally speaking, prophylactic neck dissection is discouraged for thyroid cancer, but there are some cases where it could be considered reasonably. And then I want to talk a little bit about the balance between the benefit of nodal dissection versus the complications of surgery or the issue of observation. And one key point is that there has in the past been this concept that you can berry pick lymph nodes with positive metastatic thyroid cancer, and that this was sufficient treatment. And this is not what we're supporting or presenting here. These patients that end up having cervical nodal disease need comprehensive management of the various corresponding lymph node levels of the neck. So I would refer the participants to this relevant literature. One is of course, on the left side is the latest printed version of the thyroid nodule thyroid cancer guidelines from the ATA, which was last updated in 2015. And then to the right would be some literature. This is not primary literature, but this is related to the update of the AJCC cancer staging as it relates to thyroid cancer, which happened in 2017. So a quick tour through the guidelines. If you look at the top, the guidelines have really exploded over time. The first guidelines were presented in 2006, followed up by 2009, and then 2015. And you can see the number of recommendations, the number of pages of the guidelines, and the number of references that support those guidelines has really exploded over time. A couple specific topics that I want to point out regarding thyroid surgery and its relation to cervical metastatic disease, including when to perform a total versus a hemithyroidectomy. Certainly, one of the major paradigm shifts that we see between the 2015 guides and the previous guidelines was more deployment, more appropriate and evidence-based deployment of hemithyroidectomy versus a blanket approach of doing total thyroidectomy on all thyroid cancer patients. So the recommendations point to total thyroidectomy for T4 disease and hemithyroidectomy for lesser disease. And sometimes a total thyroidectomy would be deployed if there was bilateral cancer or if there were aggressive histologic features which would warrant postoperative radioactive iodine therapy. But certainly more deployment of hemithyroidectomy for the smaller lesions less than 4 centimeters and without significant extrathyroidal extension and without cervical lymphadenopathy. And then finally, for lesions smaller than 1 centimeter, and this line in the sand has been moving a little bit. Some people have taken it up to 2 centimeters, but certainly the 1 to 1.5 centimeter area with no cervical lymphadenopathy consideration for observation might be appropriate. We'll talk a little bit about this as well. The central neck dissection is indicated for N1A positive disease. Of course, N staging for thyroid cancer is different than squamous cell carcinoma. You have N1A if you have central lymphadenopathy and N1B if you have lateral cervical adenopathy. There is mention of the appropriateness of doing a prophylactic central neck dissection for T3 and T4 disease that is N1B positive. And one of the reasons, and we will explain this further, is that the level 6 is the first echelon lymph node level for the majority of thyroid cancer. And so if you have something that is clinically N1B positive, and there's nothing appreciable in N1A, this was the pass-through level, and there's likely microscopic disease there. This will probably be appreciated at the time of surgery, and so it's appropriate to plan for and execute central neck dissection in these cases. Central neck dissection performed prophylactically is felt to be unnecessary in T1 and T2 N0 cancers. And then, of course, the observation. Observation is frequently mentioned in the text as a possibility, but only is it spelled out in one particular guideline, and that's recommendation 10B in patients that have had multiply repeated non-diagnostic FNAs off nodules, that these might be appropriate to observe. That is subject for another talk. So what do we know about differentiated thyroid cancers? And what I mean by that is papillary and follicular. They're considered differentiated thyroid cancers, which represent 90 to 95% of all the thyroid cancers that we're dealing with. In a study of 40,000 thyroid cancer patients, you could see that there was a significant positivity of nodal positivity, 20 to 50%, and 90% of the nodal positivity were microscopic nodal mets. And one can argue, well, what's the life history of these? Are these going to grow with time? Well, many do. One can also argue, well, these are small enough that if you were to take care of the primary disease, perhaps these would be mopped up by postoperative radioactive iodine, and that certainly happens in many cases. But this needs to be appreciated in the context of when the folks need neck dissection or not. Recent summary of 3 neck dissection studies related to thyroid cancer shows that many nodal levels are affected, 52 to 60% of level 2, 41 to 52% of level 4, and even higher in level 3, 57 to 72%. And one thing to remember about level 3 is, even though I had previously mentioned that level 6 is first echelon for the majority of thyroid cancers, for lesions of the superior thyroid pole, and this is not infrequently seen in medullary cancers because there's a predominance of C cells in the superior thyroid poles. The first echelon for these lesions might well be level 3. And of course, level 6, even though these 3 studies did not show the preponderance, there have been many other papers that show that the vast majority of nodal positivity presents as level 6 nodal disease. So when managing the neck in patients with thyroid cancer, it's important to focus on the levels of known greatest risk. And if you look in aggregate, 85% of positive nodes from neck dissection specimens are seen in 3, 4, and 6. So it's important to consider that, for example, if a person has level 6 positivity, you need to look closely in the lateral neck and make sure that there's not positivity. And if a patient presents with positive lateral nodes, conversely, you need to consider, well, those nodal metastases represent a pass-through from level 6 metastasis, and therefore those would need to be addressed in your surgical therapy. So generally, things to remember is the pathophysiology of nodal extension in an unoperated neck, because an operated neck, lymphatic flow is all changed. But thyroid tumors typically spread to their ipsilateral level 6. And then once the ipsilateral level 6 nodes are positive, they can spread to the contralateral level 6 or the level 7. And they can also spread to the ipsilateral level 4. And then, of course, once you have disease in level 4, then it can spread anywhere in the lateral neck superiorly. Now, this is a diagram that I have borrowed from the thyroid cancer guidelines. And the highlighted areas in red show all of the recommendations in risk stratification that relate directly to cervical thyroid disease. And as you can see, there's a spectrum from low to high, and most of the nodal positivity in this set of guidelines, which is 2009, shifted patients from low risk to intermediate or high risk. With the 2015 revisions, many of the risk factors which were previously classified as making a patient intermediate risk actually can be seen in patients that are overall low risk for recurrence of thyroid cancer or for ultimate mortality from the thyroid cancer. So things that I want to point out specifically is that you can still be low risk with minor extrathyroidal extension, which would make you T3. If you are nodal positive and the lymph nodes are smaller than 2 millimeters as far as their metastatic deposit, or fewer than 5 lymph nodes are positive. And then if there is no extranodal extension in less than 3 lymph nodes that are involved. These are all nodal features that, even though they're nodal, still the patient would be considered low risk. So some specific guidelines as it relates to lymph nodes and diagnosis of lymph node positivity. As far as recommendation 6, thyroid sonography with a survey of the cervical lymph nodes should be performed in all patients with thyroid nodules. And this is sort of preaching to the choir of head and neck surgeons, but up until recently, not all thyroid ultrasounds included a systematic and a proper cervical lymph node examination. So this is very important. And then on the right side, you see the various lymph node characteristics and their corresponding sensitivity. A lot of the diagnosis of thyroid cancer, both in the gland and the lymph nodes, can be made with the ultrasound. Usually, ultrasound-guided fine needle aspiration cytology is not to make the diagnosis, it's to confirm the diagnosis and to guide extent of management. So as you can see on the right side, microcalcifications and cystic features are highly specific in lymph nodes, whereas other elements of ultrasound, such as vascularity, echogenicity, and round shape, are a little less helpful, but still important and should be taken in context. In recommendation 33, the preoperative use of cross-sectional imaging studies such as CT and MR with intravenous contrast is recommended as an adjunct to ultrasound. Now, these are usually held in reserve for people who have large primaries, a real posterior placement of their primary, and this might be clinically evident based on presentation with hoarseness, or patients with really bulky or multiple lymph nodes. This has also been confirmed by subsequent American Head and Neck Surgical Society guidelines. So these, again, this is used so much as a tool to diagnose, oh, I have metastatic thyroid cancer in the neck. It's for mapping purposes and preoperative planning, and as an intraoperative guide during neck dissection. Routine preoperative PET scanning is not recommended, and that's a separate talk as well, but a lot of times patients will present with findings related to thyroid cancer as incidental findings for PET scans done for other reasons, and that's fine. That information can be used for treating the patient and managing them, but as far as a first-line test, it's not recommended. Recommendation 36, patients with N1A disease, it's indicated to perform a central neck dissection if you're planning on doing a total thyroidectomy. And this is related to the potential need or desire to use radioactive iodine postoperatively. Prophylactic central neck dissections for CN0 should be considered for larger stage disease, T3, T4, and in patients that are CN1B positive. Because again, you'd want to clean out the central neck if this would affect further therapy. And the further therapy would be the potential use of radioactive iodine or concern of a central neck recurrence, and then having to go in and do revision surgery in the central neck, which would then increase the risk profile as far as vocal cord injury, vocal nerve injury, and hypoparathyroidism. No prophylactic central neck dissection is recommended for T1 and T2 lesions that are clinically N0 and most follicular cancers. Recommendation 37, the lateral neck compartment node dissection should be performed for patients with biopsy-proven metastatic lateral cervical adenopathy. Now, just like size matters in whether you biopsy a lesion in the thyroid, there has been discussion about whether size also matters for lateral neck disease. And certainly there are well-respected thyroid surgeons who have noted after the thyroid surgery was done primarily and a neck dissection was never performed, that a small lesion would appear. And these small lesions, especially the ones that are more lateral and unlikely to cause problems acutely because of growth, can be observed. And some have been observed for many years, and some have never been operated on. So this is something to consider. If you find something that's small, another question that comes up is, do you biopsy it? Well, if your intent is to observe it, then one could argue don't biopsy it. Only biopsy it if you're planning on ultimately operating on those neck lymph nodes. So there was some literature put out in the form of a review and consensus with the lateral neck that I was privileged to head up, and this was published back in 2012. And some of the data gathered for this paper was then used to inform some of the subsequent guidelines that were updated in the 2015 guidelines. Here's one of our tables from the systematic review, and we look at various features which might predict the extent of lateral node disease and differentiated thyroid cancer. And as you can see, it's a long list. Anything from primary size to gender and the effect of a previous neck dissection. So these are all things that need to be taken into context when evaluating these patients. Some of the take-home conclusions from this consensus review include consideration of biopsy of any highly suspicious lymph node in the lateral neck without regard to size if a positive FNA would alter the clinical management. So yes, size matters, but it doesn't make the entire story. And so it needs to be taken in appropriate perspective. Routine elective neck dissection of level 1, 2, B, and 5A is unnecessary when an ultrasound evaluation shows no suspicious nodes in these more peripheral areas, nodal levels of the traditional lateral neck. In cases of lateral neck disease, a comprehensive neck dissection of levels 2A, 2, 4, and 5B should be performed. In revision lateral neck dissection, focus should be upon the levels of demonstrable recurrence, and a prophylactic lateral neck dissection is not recommended by ATA guidelines, and this is of the lateral neck. So let's talk a little bit about recurrence in the operated neck. When do we clinically see these? Well, a patient that has a history of thyroid cancer that then presents with a palpable neck mass. Alternatively, these may be discovered while the patient's undergoing routine post-op thyroid cancer surveillance and the lateral neck or central neck is examined. The first clue to a neck recurrence might be a slow elevation of thyroid globulin, or in the case of a person that has positive antibodies, it could be elevation of thyroid globulin antibody, which serves as a proxy for thyroid globulin in thyroid globulin antibody positive patients. These patients might undergo a post-operative surveillance radioactive iodine scan, or in the case of a patient that has been demonstrated to have a tumor that does not take up radioactive iodine, a surveillance PET scan may be ordered in the context of elevation of thyroid globulin levels. These are all common ways that recurrent thyroid cancer in the neck can present. It's important to recognize that once you've had a neck dissection, a lot of the lymph node patterns which we've highlighted are changed because the lymphatics have been excised or the flow between lymph node levels has been altered because of scar tissue. It's important to realize that this is largely an image-driven exercise. In patients that require reoperation, it's also important to appreciate the incidence of extracapsular extension is increased. Lateral neck recurrences tend to cluster in level 4, 5B, and 2 because the initial neck dissection was likely inadequate. And we see this when we're reviewing pathology data from people undergoing neck dissections for thyroid cancer. The neck nodal yield from a lateral neck dissection in thyroid cancer operations in some patients is low. It's 10, 12 lymph nodes. And that should raise flags that this has been a neck that's been underoperated. And Dr. Tufano noticed that there are common areas that are listed above where these recurrences are found. And as far as 5B is concerned, this is particularly interesting because this oftentimes is not addressed by most people with lateral neck dissections. And in fact, we know that neck nodal disease can go from the thyroid to level 6 to ipsilateral level 4, and then it follows the lymphatics along the cervical vessels in the low neck out to level 5B. And so this explains in that case. Level 2, likewise, if you have positive level 3 disease and level 2 is never excised, it's not uncommon to see disease in level 2A or 2B. And so it's important to appreciate these patterns. When you're doing a revision neck dissection on somebody, the focus should be on the levels of the perhaps nodal tissue that had been left behind by previous surgery, but certainly on the nodal levels known to harbor recurrent disease. Just a quick word about the AJCC 8th edition on differentiated thyroid cancer. It's important to know that you can have extrathyroidal extension in a limited form and still be T3 disease. This does not make you automatically T4. And probably most significant and something that really was impactful in counseling our patients is the change of the age from 45 to 55 as far as being low risk T1 and T2 if you're less than 55, and not even being able to achieve a T3 or a T4 status until you're 55 or older. So when considering the neck and thyroid cancer, it's important to do a very fastidious ultrasound examination. Level 6 can be a challenging level to appreciate on a preoperative thyroid ultrasound, both because the thyroid is in situ and can camouflage the nodal disease in that area. And also in the patients that we typically see where there's more obesity and the necks are shorter, this can be an anatomic challenge. Of course, lateral neck nodal inspection is very important with the ultrasound. Certainly, unguided fine needle aspiration biopsies have become largely something of the past. We're making these diagnoses and doing the mapping with the ultrasound. Why wouldn't you use the ultrasound to guide your needle tip placement to increase its precision and likelihood of significant cytologic findings? CT, again, and MR would also correspond as axial imaging. This can be used in posterior thyroid lesions, larger thyroid lesions, bulky and multiple lymph node metastasis. And there's always mentioned the concern of, well, I don't want to give that patient a bolus of iodinated contrast if I'm planning on giving radioactive iodine. Although this is a logical thought, if you think about the timing of when a person gets a pre-op CT scan, when they likely go to surgery, after they recover from surgery, and then when they're ready to receive the radioactive iodine, this is typically a 2-month period of time. And research has shown that the iodine load is largely dissipated by that period of time. And if you have a question about that, you can always do a urine collection for iodine to prove that the patient is no longer saturated and is going to effectively uptake the radioactive iodine. So just a few additional words about PET. There's really no role for PET in the initial diagnosis and evaluation of people with differentiated thyroid cancer. It has a limited role in surveillance in people, particularly that are thyroid globulin positive, that have a rising thyroid globulin and are known to be radioactive iodine negative. The most common place where we see PET scanning is with differentiated thyroid cancer that presents as an incidentaloma when a patient's been undergoing surveillance scanning for other malignancies. So I'd just like to briefly talk a little bit about the Japanese experience as it relates to prophylactic neck dissection. And these slides were graciously shared with me by Dr. Miyachi from the Kuma Hospital, who is a world leader in the observation strategy of small thyroid cancers. And this has extended to even observation of some thyroid cancer nodal neck disease. So at the Kuma Hospital, there are basically 3 time domains where they had made a change in their practice. Prior to 1996, everybody, or almost everybody, got a prophylactic neck dissection. As you can see, the vast majority, almost 80%. From 1997 and 2005, as they were deploying clinical ultrasound more in their practice, there was a trend towards less, yet a significant percentage still, 60% of patients were undergoing prophylactic neck dissection for thyroid cancer. Then you see a dramatic change going from almost 80% initially down to 10% from the epic of 2007 to the present, where the patients were largely not undergoing prophylactic neck dissection. And here's a little bit of background information. So between 1987 and 1995, there were 1,200 papillary thyroid cancer patients without detectable metastasis in the lateral compartment who underwent thyroidectomy, central node dissection, and a lateral prophylactic lateral neck dissection. And if you look at the numbers and the relationship between the lateral node metastasis and tumor size, you could see certainly a trend with a larger primary tumor. There was more likelihood of nodal metastasis, and you could see more lymph nodes, as is highlighted with the red box. If you were to take these groups of patients with having thyroid tumors that were smaller than 3 centimeters and ones that were larger than 3 centimeters and follow them for up to 20 years, you could see a difference, which was statistically significant, although it was not as dramatic as you might expect. And further analysis in the factors related to their neck disease was done in a later cohort where they identified tumors larger than 3 centimeters, significant, not minor, but massive extrathyroidal extension, and older age and male gender. And all of these on univariate analysis were statistically significant, and likewise a multivariate analysis. And these generated hazard ratios that could be translated into clinical recommendations. And then these risks were then further placed into a scoring rubric where a tumor greater than 3 centimeters, yes or no, got a point, and the same for extrathyroidal extension, old age, and male gender. And this came up with a point system. And when you had 2 or more points, these were then patients that were sent on for prophylactic modified lateral neck dissection. If you look in the patients in this context, you can see a greater discrimination of outcomes as it relates to patients that undergo neck surgery. So the top line, which shows 0. And this was almost half of their group. And then another third of the group had a risk of 1. But as your risk increases to 2 or 3 or 4, which represented certainly a minority of that population, you can see a significant decrement in long-term survival. So if you look at these cohorts based on the time, and we explained previously the time as far as when everybody was getting prophylactic neck surgery, when lots of people were getting prophylactic neck surgery, and then when it was being more selectively deployed in groups A, B, and C respectively, you can see statistically significance in the outcomes. And of course, this was excluding in all these periods of time the ones with the most aggressive thyroid cancer, the super elderly people 75 years and older, ones with known metastatic disease, and ones with neck positive, lateral nodal positive disease in that context. So if you were to use the high risk, low risk, and perform neck dissections, if you were to perform neck dissections and look just at the high-risk patients and compare those to patients that did not get a neck dissection, you can see obviously a very significant difference in those. So certainly risk is important, and observing some low-risk patients and not performing neck dissections is appropriate, but certainly that needs to be deployed appropriately. So central neck dissection, what is this? A lot of people, this is 20 years ago when I was first getting really active in endocrine surgery. This was enigmatic to a lot of people. People were familiar with the term, but they didn't know exactly what it entailed, when it was performed, how it was performed, and didn't really appreciate how it, when performed frequently and not in a skilled fashion, subjected patients to significant risk. So I'd point your attention to an article which is a little dated at this point, but very important because this was one of the planted what is and what is not a central neck dissection. And I would refer you to that for some terminology as far as prelaryngeal, pretracheal, and paratracheal lymph nodes, why we call them that and where they're located and why that's significant for a central neck dissection. And once this consensus was put out, we were able to establish a standard of what is included in a central neck dissection, which is removal of prelaryngeal and pretracheal nodes and removal of one or both paratracheal nodal bases. So this would be off to the left, off to the right, and specifically in the central neck, that this included removal of lymph nodes from the level of the cricoid cartilage down to the level of the innominate artery on the right, or to the carotid on the left side as it's going into the aortic arch. And that a central neck dissection is not berry picking, but is a compartment-oriented neck dissection. The central neck is really considered to be a single midline compartment, but when it's managed surgically in order to mitigate risk postoperatively, it's oftentimes considered I remove the lymph nodes on left level 6 or right level 6 or bilateral level 6. So therapeutic level 6 is when there is known positive neck disease that's removed. Now this can be appreciated preoperatively, or many times it isn't appreciated until the removal of thyroid gland, and upon intraoperative inspection, whether that's by ultrasound or digital palpation or visual inspection, it's appreciated to be positive.
And then, of course, we've already talked about cases where prophylactic or elective central neck dissection is appropriate. So with a focus on level 6, should we always remove level 6? And if so, should we do it unilaterally or should we do it bilaterally? And we shouldn't forget that the risk of hypocalcemia and recurrent laryngeal nerve paralysis, and a worst case scenario that there's a bilateral paralysis which might require tracheotomy. So the surgery really should be guideline driven, and it should be completely done and comprehensively managed. So here's some guidelines as it relates to the central neck dissection. Therapeutic central neck compartment neck dissection level 6 for patients with clinically involved central nodes should accompany the total thyroidectomy and clear the disease from the central neck. Prophylactic central neck dissection, ipsilateral or bilateral, should be considered in patients with papillary thyroid cancer with clinically uninvolved central neck nodes who have advanced primary tumors or have C1NB disease. So to review, on larger lesions, known poor histologies, patients that present with advanced age, certainly in medullary thyroid carcinoma, these should all be things that would cause the surgeon to entertain doing a prophylactic central neck dissection. So briefly, I just want to show you this cartoon that walks you through the steps of a central neck dissection. And it's important that we're taking the tissue off the trachea and off of the carotid sheath. We're preserving the recurrent nerve. We're preserving at least the superior parathyroid, and oftentimes the inferior parathyroid is removed with the central neck dissection specimen and could be reimplanted if felt to be free of disease. So again, just to repeat those steps, and then following this, I am going to show you a short video as we work towards the end of this talk. Here the ipsilateral thyroid lobe is being removed and setting us up to start to examine the central neck. So there you see the recurrent nerve, which is being confirmed by intraoperative nerve monitoring and is intact. So here you see interrogation in the process of dissecting and skeletonizing for the purposes of preservation the recurrent laryngeal nerve. There's the recurrent laryngeal nerve that's highlighted. And you're taking this dissection right up to and underneath the innominate. This is a right central neck being performed. And now the disease is being mobilized medial to the recurrent laryngeal nerve and being delivered off of the trachea. Again, you see as part of the procedure, all the tissue prior to it being excised is interrogated for neuromonitoring. level 6 transitions into level 7, and in fact, oftentimes when I'm doing level 6, I'm taking out superior level 7 as well. And this can be easily done with a comfort with the anatomy and practice. Now, if you notice, we're taking out the central specimen, and you can see the contralateral positive level 6 there underneath the strap muscle. That is later removed. There's your recurrent laryngeal nerve. There you see the posterior branch of the recurrent laryngeal nerve. That's going to the cervical esophagus. Now, oftentimes, the nodal tissue deep to the recurrent laryngeal nerve needs to be taken out as a separate specimen. Here we're doing something we frequently, which is vagal nerve stimulation, and this has the advantage of ensuring the entire nerve circuit from the vagus all the way to the vocal cord is intact. And we're doing that prior to mobilizing the recurrent laryngeal nerve, and you can see some deep tracheoesophageal groove nodes, which are positive. And these are sometimes left behind in people that are a little timid at skeletonizing and mobilizing the recurrent laryngeal nerve, and then would represent recurrent disease, which would be a difficult revision surgery. So it's advised to take these out at the primary surgery if at all possible. Again, we interrogate before we excise to ensure that we're going to have intact nerve function post-operatively. And literally, this disease not only is taken from underneath the recurrent laryngeal nerve, but it's taken off of the esophagus, and you'll see that better once the specimen is taken out. So you can see the carotid, the recurrent laryngeal nerve, you can see the esophagus, you can even see the spine in this patient, which will all be highlighted momentarily. And that's your central neck dissection specimen. You can see multiple positive clinical nodes there. So the complications of hoarseness are significant when you're performing central neck dissection, and really care and experience is critical to mitigate this. Doing preoperative flexible fiber optic laryngoscopy, which are codified not only in the ATA guidelines, but in also the American Academy of Otolaryngology Head and Neck Surgery guidelines on nerve monitoring and laryngoscopy. You definitely want to avoid a case where you'd have bilateral true vocal cord paralysis postoperatively, and so this is one of the reasons for intraoperative nerve monitoring and consideration of stage surgery in patients that have a diminution or loss of nerve signal during surgery. Also, hypocalcemia and hypoparathyroidism, whether it's transient or permanent, are significant potential complications, and this can be mitigated through intraoperative parathyroid monitoring, meticulous surgery, identification of parathyroids, and perhaps reimplantation, and perioperative calcium therapy and vitamin D prophylaxis. And these are recommended in Lisa Orloff's ATA statement on postoperative hypoparathyroidism from 2018. How do you know if you've done good central neck dissection surgery? Well, you should have 5 or more lymph nodes obtained. You should really have a low threshold to reimplant a parathyroid if you're concerned about your parathyroid preservation. Cautiously dissect in the region, the innominate artery, in order to avoid potential thoracic duct injury or lymphatic duct injury in the case of the right, which can be a postoperative complication of significance. And since you're doing oftentimes lateral and central neck together, you can stimulate the vagal trunk easily, and this will allow you to have a global appreciation for nerve function. Just a quick word on lymphatic leaks. As in this talk, this is some literature that we recently presented. There is a concern of lymphatic leaks with thyroid neck dissections surgery, especially when you're doing both level 6 and lateral neck nodes. And this could be a result of the disease, but it could also be a result of the technique and the volume of the operator. So these are all things you want to consider. Do Valsalva testing, do abdominal pressure. If you're doing a lot of neck work in low level 4 and level 6, where you may functionally excise circumferentially around the lower carotid, there is a higher likelihood of lymphatic leak in these cases, and it's best to diagnose those and manage those intraoperatively than to experience them postoperatively. So to summarize, preoperative imaging by ultrasound and or cross-sectional imaging should drive the need for neck dissections. A focus should be on levels 4, 2, 3, 6, and 5B in the comprehensive management of neck disease and thyroid cancer patients. Revision neck surgeries are based on resection of recurrent nodal disease within levels that have been preoperatively defined by imaging. There is no recommendation of prophylactic lateral neck dissection for thyroid cancer, and great care is required for effective and safe central neck dissection surgery. I'd like to thank you all for your attention. I would open this up for questions at this time, and I appreciate your attention. Thank you very much.
Thank you, Dr. Stack. That was great.
Thank you so much. I appreciate it. And Dr. Chen, have a great lecture.
Thanks, Dr. Stack.